Thank you, Alexa, for that very nice introduction. Maybe I'm just going to share my slides here, or our slides.
Yeah.
Sorry, I just have to change the display setting. So you're not looking at my chat, my notes. Hang on. Frozen. Oh. All right. Thanks very much. So Yana and Renee are going to monitor the chat. I cannot see it while I'm speaking. So if they need to interrupt me for any moment, please do so. We want this to be fairly interactive, and so we encourage participation. And yeah, thanks for your time. So Alexa introduced us. So I won't provide too much more context, just to say that we co-produce this webinar as researchers and lived experience advisors who work on projects related to the impact of AI in psychiatry. And it was a great learning experience, I think, for all of us to sort of unpack some of these assumptions and misunderstandings that we have. We thought this would be a really valuable thing to share with the wider patient and family community. So why are we doing this webinar? Renee and Em or Nelson, maybe you want to chime in why you think this is important?
Not all at once, right?
That's Em. Em, what's important about this?
Well, I think it goes in line with what we're talking about, living experience. That's me. I have a lived experience of dealing with mental illness, and so for me, the webinar is to ask people more than just us sitting on the panel here, sitting on the research team, who've been really inundated with this information and talking about this information, to reach out to other people and feel the climate of what other people's experiences are with AI and what other people's thoughts are, what the concerns might be, and to get more living experience and input from a broader community.
Yeah, thanks, Em. Well said.
Yes.
Yeah, our goal really is to engage patients in these conversations about the impact of AI on psychiatry, to really center the patient experience. And so we hope you learn something from this, and we look forward to your thoughts. Renee, did you have something to add?
Well, no, I just wanted to say that I think along with many people today, wonder what is this terminology and where does it fit into our life and where will it? Because yes, the future is here now. This used to be something we'd see in movies and see all these robots and wonder if this was what was going to, be leading the world around by robotics and automation. And so there's a part and a place for everything now. And this is one of the last frontiers that we're utilizing artificial intelligence for.
Yeah, well said. Thanks, Renee. All right, so just a brief, just the agenda. So in 3 parts, we want to introduce you to some core concepts, which are artificial intelligence, big data, and machine learning. We will talk a little bit about the applications related to AI in psychiatry around improving diagnosis, treatment, and care. And we will conclude with a discussion about the AI and you, in particular, your data, your health data, and your care. Great. So the first question we want to ask you is, when you hear the term artificial intelligence, what do you think of? So feel free to just shout out a one-word answer or put it in the chat. Fearful. Oh, robots. Ominous. Oh, wow. algorithms, technology, monitoring, oh, surveillance. Yes. Anything else?
I think of C3PO, but I guess I shouldn't answer.
Robots. Yeah, I think I'm so I'm glad we're doing this because it sounds like AI has this tone of can be a very anxiety producing concept. So I think this will be helpful for you today because our goal here is to unpack what AI really is and what it looks like in psychiatry and to take it away from the realm of science fiction. So just as a heads up that the concept of AI is actually a bit of an umbrella term. Everything but the kitchen sink gets lumped into it. Robotics, path planning, deep learning, all these things are quite complicated. But really, it's a big term for a lot of different things, and not all of these things are going to be used in psychiatry. And not all of these things are appropriate for healthcare context at all. So it's important to understand that there's a ton of diversity in this space. And the ones actually being used is the one we're going to talk about today is machine learning. And why, so we're really narrowing down to a very specific kind of AI that will have impact on psychiatry. These other things, while interesting, are less important for this space. So what is AI? So really, basically, at its most basic, it's the use of computational tools to solve problems traditionally requiring natural intelligence. And by computational, really just mean doing math with computers. So AI has been around for a very long time. This is a photo of Arthur Searle, who produced the checkers machine on an IBM computer in the 1950s. So as you can see, this computer was enormous at this time. And that's the kind of, giant machine that we needed back then to do math on a computer. Now, probably the most common robot that lives in our homes is the Roomba, which is a kind of AI that you might not think about as being a robot, but it kind of is. And the idea is that it helps solve problems. So while checkers was kind of an innocent game board, sort of an experiment designed to have fun, in this case, referring to a New York Times article, the robot is designed to ease worries, save time, make life easier, keep your house clean. So these are human problems that computational tools, math and computers combined, can solve. So the Mythbuster here, right, is that we are going to have these autonomous machines running around doing healthcare work. And I don't know, are there any Star Trek fans out there? I'm a Star Trek fan, but if anybody ever watched Star Trek Voyager and is familiar with the hologram doctor, he was an emergency medical hologram. So 300 years from now, there is an imagined vision of a kind of autonomous robot that can offer care to patients, but this is very much the realm of science fiction and not the reality of what AI will look like in psychiatry at any time soon. More importantly, these computational systems, while we think of AI and machine learning as a computer thing, in fact, they cannot operate without humans. And there are multiple humans involved in the development, supervision, auditing of these tools. So you cannot, there are always humans in the loop with these workflows. We're still figuring out what those systems will look like. But there's no way in healthcare these would operate autonomously without human oversight. And in particular, in the healthcare context, one of the reasons we are doing this is because we want to engage patients and families in this loop, right? We want people like Renee and Em to engage with the projects, provide their insights, to support patient-centered and compassionate care. So part of the reason we're talking about AI now in 2022, even though it's been around for at least 70 years, is the emergence of two things that have happened. One is computers are much smaller than the one that was used originally. They're much faster. They can store a lot more information. And that is typically called big data. And so when we talk about big data, we mean many different things. We mean different kinds of data. The variety of data has increased. So your healthcare records might have information about lab test results, MRI imaging data, self-report information. There's also Twitter feeds, social media. There's a tremendous variety of data that exists these days. Combined, this data can provide better accuracy, which is called veracity. So it's more accurate because it's triangulated from different angles. There's also so much more of it now, right? So when the checkers machine was first invented, he actually had to, there wasn't enough storage on it to even really do the whole program. He had to shade out the storage boxes to make it work. That is not the case anymore. We can store tons and tons of data in a way not imagined in the past. And also we have instant access to this data through smartphone, Fitbits, wearable devices, and so on. So the velocity or speed at which this data has happened has changed a lot of things. However, anybody who tells you that big data can save healthcare is not telling you the truth. Big data is part of this picture in healthcare, and it is only the quantifiable dimension. And I want to, this picture here sort of shows that big data is the yard, right? He's mowing the yard. He knows what's happening here, but this tornado that's bearing down on him is something that perhaps we might not be measuring. In healthcare, we could think of COVID-19 as being that tornado. Didn't see it coming. It's had a tremendous impact on care that will be felt for years to come, right? And so we can only measure what we think to measure, which is big data. And there's a lot of other things that we can't measure. So it's not possible for big data to cure us or save us or help save our health system, although there is tremendous potential. So the primary way that big data is analyzed is with machine learning. Keeping in mind that the machine involves humans, like data engineers, data scientists, and so on. So these are computational systems, which are both human and computer, designed to analyze, make predictions, and learn from patterns in data. So what is unique about machine learning compared to other computational statistical tools is this ability to make predictions with new data and to learn from data. So in this constant way. So an example of how this works in non-psychiatric settings are machine vision tools. So machine vision tools are tools where they take images, and from these images, the computer can learn to detect patterns and make predictions. So in this case here, it's to look at people's feet who have diabetes, and through this machine learning algorithm and tools, it can predict whether or not that person has a wound that could result in a preventable and unnecessary amputation. These kinds of tools are in oncology, in a lot of cancer care, for example, because images, it's very clear when someone has a tumor. It's not so obvious in psychiatry how this kind of tool would be used, but this is one way where this is working. So how the data scientists program, how the machine learning works, is that there's a whole bunch of data, let's say hundreds and hundreds or thousands of pictures of people who have wounds on their feet. You tell the machine which one of those people ended up with an amputation or not. It learns that and then, builds a model. Then you give the machine new information, and then it can predict, like you have a client who comes in the clinic, you take a photo, that's new information, and it can predict whether this person, for example, might have a wound on their foot, right? So here it learns new information from a new photo, and it makes predictions. And just to sort of demystify the idea of algorithm, an algorithm is just a process or set of rules to solve a problem. a Rubik's Cube, solving a Rubik's Cube is an algorithm, but it's not done by computers. But algorithms done by computers are the ones that we're talking about now. They're just a set of rules that a person designs to have the data do certain things, the computer do certain things. However, going back to the example of the doctor from Star Trek, he was essentially a superset of algorithms. He had dozens and dozens of algorithms in his matrix, which is what they called it, that helped him predict care and to humans. However, in one episode in season 5, his ethical algorithms are deleted to serve the enemy ship, and he turns into an evil bad doctor, right? And the point of this story is that computational systems are human systems. Our choices matter. This is why patients and families have a say, and we really want to involve them to the greatest extent we can. Because how we design these systems has a huge impact on how they work. So an example is that throughout Star Trek Voyager, the engineer, B'Elanna Torres, is constantly tinkering with, improving, helping the doctor with his program, right? So he is not able on his own to function. There's always this sort of human oversight over his system. And so we should always think that AI in psychiatry will never operate without human oversight and should not be developed without patient and family involvement. So just to summarize these 3 key concepts, first is that AI is an umbrella term used to refer to computational systems, which are humans and computers, tools like machine vision, and AI-enabled devices. So we think of Siri or Uber, right? These are all systems or apps that are enabled by this big data and these machine learning tools. In healthcare, sources of big data include social media posts, electronic health records, wearables, internet search histories, lab test results, imaging results like X-rays and MRIs. All of this information can be used to drive transformation in care. The central way this big data is analyzed is with machine learning tools, and there's lots of different ones. The technicalities of it aren't all that important, I think, for the everyday person. But this is how we analyze big data. And the ability of machine learning tools to learn and make predictions opens up really exciting possibilities in psychiatry. So this is what's unique about machine learning, is the ability to learn and make predictions. And we're going to talk a little bit about what those might be. I saw someone made a comment in the chat. If I need to pause here I wasn't able to read it, but we can circle back to it at the end. I don't know, Alexa, I see your face. What do you think?
I mean, I'll read this question out to you, and then maybe we can, we'll collect all the questions and do it at the end. But this one says, oversight is important, but how are we to balance the human AI relationship? Seems possible that one might prevail depending on the situation.
Yes, I think that's an excellent research question. Which one will prevail? I think, our team, absolutely says patients should prevail and providers, but obviously not everyone would feel like that. And Nelson's going to also speak to it a little bit. Thank you, Nelson. Okay, so what are these exciting possibilities in psychiatry? And we're not going to be able to delve into all of them. We're going to give you 3 examples. And I would say that all of these tools are in development. They're at this stage not deployed per se, right? But of course, one of the ways is in drug discovery. So just in developing a model that can help predict treatment response so that you improve you find the right treatment for the right person. Psychotherapeutic interventions like chatbots, diagnostic tools, so tools like the machine vision tool I showed you, but for psychiatry, How can we improve the diagnosis of things like bipolar and schizophrenia? Decision support. So how can we provide psychiatrists with information that will help them make treatment decisions with their patients? Prognostication, which means how do we make decisions about someone's care? So for example, I'm involved with a project with traumatic brain injury where a major issue patients have is around knowing, should they move back in with their parents, or are they going to need personal support worker? So knowing what their long-term outcomes helps them plan and make decisions about their life. And of course, early detection and prevention, you can see how with youth, this would be really helpful. If your sleep patterns are disordered and it sort of notes that, oh, maybe this is really bad for you in particular, it could send you a warning to say, oh, you should try and get more sleep, right? So there are ways that these tools are being developed, lots of exciting possibilities at this stage, no real tried and true proven method. So just to look at the 3 examples that we have, and these are being developed at CAMH, are psychotherapeutic tools and decision support tools, especially around smartphone applications. So these tools are, the idea is to support care and help enable conversations with your psychiatrist by having access to this information. A second is around diagnosis, and maybe you want to say, but from a lived experience perspective, people in psychiatry often move through multiple different kinds of diagnoses. They might try many treatment regimens before they find the right medicine for them, and this can be a really time-consuming and stressful process. So has a song that you were able to stream to sort of like get at this process. Did you want to read it?
I can play it. Can I play it?
I think the challenge is video on this.
Okay. I just don't know if I click it, if it will play. It'll play from here. So then can people hear it? That'll be the question.
Oh, yeah, that's always the challenge. What you could do is put it in the chat and people could listen to it on their own. Yeah.
I'll do that. Okay, so this idea was that basically at a certain point it was so many diagnoses that I started to feel like it was a Johnny Cash song. Like I've been everywhere. I've been to Minnesota, Sarasota, Dakota, Minnesota. It was you have a titch of depression with a side of anxiety and a little bit of PTSD and anxiety and MICKEYMOUSD, and it gets overwhelming. And this song is clearly humorous, and and that's what it is. I'm just going to say that's good enough for an explanation. And I will paste it into the chat for people's listening pleasure later.
Yeah.
I will do that now. Yeah.
So this is a very real challenge for patients and families. And these tools could help refine this process so that people aren't bouncing back and forth or living with that uncertainty for a long period of time. And finally, the options that we mentioned earlier are around patient level changes, but these tools also have the possibility of population level or public health intervention. So for example, this link here will provide you some information on how big data and predictive models or machine learning could be used to support harm reduction initiatives with the drug toxicity crisis. So for example, it could be used to redirect paramedics to locations or provide drug screening to identify toxic drug sources. So there's a range of options here that would be at the higher population public health level that could improve for something like the drug toxicity crisis. All right, so at this stage, I'm going to pass it over to Nelson, and Nelson is going to talk about AI and you.
Oh, okay. Am I sharing my own slides?
Oh, I was going to do it. I don't know. Sorry, I don't know why that stopped.
I can.
Sorry. So Nelson, if you want to do the polls, I have to make you a presenter.
Let's see.
So it's a little, yeah.
Okay, it's okay. I'll just share my slides. Keep it simple.
Okay.
All right, sorry about that, everyone. 1 second here. All right. So hi everyone. I'm Nelson. I'm a researcher here at CAMH, and one of my roles here is patient and family engagement, and I do a lot of that in respect to how technology is being used, and getting your thoughts and feelings about and expectations around it is really important for me. So one question I really ask in some of my studies is, how do you feel about the use of your health records for AI applications in psychiatry? So feel free to unmute yourself, share your feelings about it, or put it into the box. And now I cannot see my box anymore, so the chat box. So let me see if I can reopen that. There's chat. Oh, there's chat. All right, yeah.
I would just comment just a little bit here that I think most people might feel that they would like it to be anonymous. So would that information be anonymous?
Great point, and that's a bit of a spoiler, but we'll we'll get to that point. Yeah. Earlier, I heard ominous, which is a very kind of scary term, and also fearful. I heard as a challenge. I don't see anyone in the chat. Oh, worries about confidentiality. Thank you, Alexa. Yeah, that's usually the biggest one. Worries about confidentiality. What about my privacy? What about hackers? And so forth. I feel okay. That's great. Anyhow, I guess everyone is a bit reserved with their feelings on this issue, and maybe I think it takes time, a bit of time to process what AI actually is, and what Laura just shared with us. So to follow that question, so here's a poll on how do I activate poll. If I can't activate poll, maybe I'll just ask you to reflect on this. Oh, there you go. There's my poll. So open poll. Oh, okay, this is my first time using poll, so maybe we won't use the poll, but maybe this will be just a reflection. Oh, are there answers? Oh, okay, yeah, sweet. So the question is, do you know how your health records are being used by CAMH? Pretty important question, I think. So so far I have eight who answered. Okay, we'll give it one more second. Okay, I'm gonna close the poll, and I think I can. So what we had here was three people said they. Oh, can I show the poll to everyone? Okay. So four people said kind of, 7 people said no, and some people didn't answer the question. That's kind of a lot of my research looks at, well, what are the privacy experiences of people, and that kind of is very in line with what I see in the Canadian public of how well do you know how your health records are being used. So in my research, I also like to have like a rapid round of did you know? And so the first did you know is did you know how CAMH uses your records? So the three types of uses, or three types of things they do, is either collect, they either use, and disclose your personal health information. So at CAMH, everything is done by the law, and the 2 laws in Ontario are the Personal Health Information Privacy Act, which governs all use of health information within healthcare, so any health-related information. And then the other one is the Freedom of Information Protection of Privacy Act. So that one governs the use of information that is used by government and some of its agencies, and as a proxy in healthcare as well. So at CAMH, we have to follow these rules or laws. So I tend to hate slides with a lot of words, so I really apologize for this, but here are the ways CAMH collects, uses, and discloses your health information. So one, it's to provide you with healthcare. I think that's the obvious one that most of you will know about. Sometimes they'll need it to consult with other healthcare providers if they don't know something. For OHIP purposes, or WISB, any sort of private insurance. So those are kind of things related to your direct care. But then outside of that, I'm not sure who actually knows this, but we actually use your data to manage and administer programs and services at CAMH, and sometimes for research as well. And usually in these cases, you know, we follow the rule that we use the minimal amount of information. So usually it's de-identified or anonymized, unless there's a very, very important use case. But in that, if that ever happens, then it has to go through ethics to make sure that, you know, what we're doing is ethical and that we're not just trying to I don't know, do whatever we want with it. Another one is teaching, and again, that's usually anonymous information. And then we'll also use the data to report to the government at an aggregate level. So everyone's data is put together and it's only reported by percentages, so that, you know, the government knows how to allocate their money and allocate their services. Sometimes it's used for fundraising activities, and then whatever purposes that are permitted or required by law. And as I mentioned, we all adhere in CAMH privacy policy, adhere to the minimum extent necessary. So you can only use the amount of information you require to do whatever task you're trying to do. So if it's provision of care, they should only be looking at what is pertinent to the care. If it's for some sort of research project, well, you can only look at what you're researching and not the whole record. And similarly with other sort of uses, you can only get what you need and not more. And we won't collect things that we don't need as well. So let's try another poll. Hopefully this one goes a little bit better. Okay, poll question number 2, open. And I'll open the poll. So do you know what is in your health records? I'm pretty sure a lot of people have an idea. My guess is going to be kind of. Because mine was kind of at first. Oh, we have one yes. That's excellent. Okay, I'll give you 10 more seconds to decide. 5, 4, 3, 2, 1. All right. Close poll. And I'll share the poll results. There you go. Do you see the results? All right. So we have 1 who knows what's in their records, which is great. 6, as I would guess, probably 6 of you, or quite a few of you, don't kind of think you know, but aren't really sure. And then there are some who just don't know. So that leads me to my next section. Well, what is in your records? So what we call your records is personal health information. So it's any identifying information about an individual in relation to your healthcare. Right, very broad, doesn't really tell you much. I'll expand on that. So examples of this include your physical, mental health, information about that, including your own history and your family history, if necessary. As I mentioned earlier, minimal collection. Who's providing the care and what kind of health care are you getting? Of course, they need your health number. They'll have some sort of record about any sort of biological samples you provide, either for medical testing or examination. So it could be like blood, tissue samples, and then some information about your payments or eligibility for healthcare. And then if those that require substitute decision maker, information about that will be on there as well. And these are just most of the things. There may be others as well. And I provided a link to the privacy policy and can check out what else is on there. The other part of your health records will include personal information. And earlier I mentioned FIPA and PHIPA. This is the FIPA part. It deals with information not related to health. So it's any identifying information about an individual in relation to their healthcare. So examples. These are the common ones that we usually collect. You know, whatever you fill out when you come into CAMH, right? Your name, date of birth, contact information, might require some demographics. And the list might go on. The list often is reflective of what's in the law, but it's not always collected. Again, whatever is needed at point of care. Okay, so one more poll for everyone, and I don't want to save. Okay, poll number 3. Open the poll, and the question is, do you know your patient privacy rights? We have some kinda, some no's. One person said yes again. Okay, we'll close it in 10 seconds. 5, 4, 3, 2, 1. All right, and we're gonna close this poll. And then I'll show the poll results. Oh, waiting for permits. Oh, they're still on submitting. Great. Oh, it has its own timer. And I apologize for this. Right. Okay, so let's see what the results say. All right, so based on these results, we had 3 people saying yes. That's great. 4 kind of, that's also great. And only 2 no. So this is great that a lot of you know what your rights are, because it's very important as we progress and use new technologies in healthcare. So I'll continue on. And so did you know about your patient rights? So under the law, you have the right to seek and ask for a copy of your health information. You can ask us to make corrections to incorrect or incomplete health information. You can ask us for a list of how we use or share our health information. Be told when your information is lost, stolen, or shared with someone without authorization, so when it's in a breach. And then you can change your mind if you previously given us permission to use or share your health information. Something that I didn't include on this list is you can also complain to the privacy office if there is any sort of grievance that you feel has been done to your records, or and they'll look into that for you. And I work with the privacy office quite a bit, and they're very friendly people there. So never hesitate to reach out. So why is this important? Why is it important for you to understand this? One, privacy is this idea where you have control of your information, and by understanding how your information is being used and your rights, you can exercise these rights when you feel uncomfortable with something. So that last point I said, you can withdraw consent whenever you don't want something to be shared. And this is in line with what the Canadian government, Ontario and Canadian government thinking. Right now, we think AI has such great potential, but they also recognize the importance of engaging patients. And we go back to this idea about oversight, both at the national level and at Ontario government levels. They're interested in fostering relationships with patients to understand what are the expectations, and also empower you to exercise your rights and know what you're sharing your data is for. So I really like this quote. This was a recent report from the Ontario Health, and it says they want to foster an inclusive data-enabled culture which enables active participation for all stakeholders. So everyone should be afforded the ability, capacity, and opportunity to participate. You have to be empowered and enabled to participate in the use of your health data. So part of this is strengthening health data literacy across all stakeholders with approaches tailored to the specific needs and interests and roles. So part of this is really, 1, educating the public, and 2, getting the public involved so that we understand what expectations there are, so we can build that into any sort of oversight or the development of how we share our data. So Ontario government's been doing a lot of patient and family engagement in the communities to understand that. And it's reflected in that report. At the Canadian level, so COVID's highlighted the need for information, and we're seeing the importance of that, and we're trying to start building a world-class health data system that is patient-centric or person-centric. So again, you're hear the same thing. It's essential to engage the public and communities to inform how we implement these strategies. So administrators, providers, and innovators need to understand the public's expectations when it comes to management of data, in particular for health data sharing and use. This better understanding would build trusted relationships to bring individuals and collective benefits. And really, without enough data, this AI cannot happen. Incomplete data means a lot of mistakes or a lot of false predictions. So that's what's so critical about this idea of securing public trust and sharing this data, so that we can leverage these things for the better health of not only yourselves but for Canadians as well. And what are we doing at CAMH on that front? So we have our Brain Health Data Bank, and there's a lot of great patient and family engagement going on in CAMH. Sorry, just blank there. But just want to highlight the one that's going on at Krembil Centre with the Brain Health Data Bank. We do have a patient and family engagement team where we do discuss these ideas as governance and oversight and how data should be used and shouldn't be used. And as in line with what those reports are saying, I encourage you to be active participants. One, either getting to know your rights and what data is being used, or two, being a part of this and letting your voices be heard. Because I think, my personal opinion, like we can't do this without the patient and family perspective, and that's just so critical to the success of any sort of AI or machine learning projects. So that's it. I'll hand it back to you, Laura.
Thank you, Nelson. So just to on that point about collecting accurate and about big data and AI, is that it is absolutely essential that the data is good quality for these models to work. So you can imagine that if you feed the algorithm poor data or skewed data or inaccurate data, then of course you will produce a very bad predictive outcome. So the goal is to always have great quality data. And one way that we can try and do that is to make sure that these outcomes are not inequitable or cause harm to marginalized groups. And so part of that process, CAMH collects your health equity data. If you've been a patient, you've maybe filled out this form called the Health Equity Form when you are brought into CAMH. And so data scientists can use this information to check the models to make sure they're not discriminating against any specific person. So an example of how machine learning could do this is in that machine vision example that I've showed you. In skin cancer, they developed a really accurate way of predicting skin cancer melanomas with photos, but it doesn't work very well with dark-skinned individuals, and that's because they didn't provide the machine in the beginning with a representative sample. So that's been fixed now, but these are ongoing concerns for all machine learning initiatives. So this data we collected at CAMH, as Nelson mentioned, it is in your electronic health record. And also, this information is used to support equitable care. So, to get access to this information, though, we do have to apply for REB approval and go through the proper channels. We can't just get access to it, that easily. You have to have a reason to do so. Right. So, I guess lastly, we just want to touch on this issue of the care experience. And I think the words that people use to describe their feelings about AI in the beginning, ominous, fearful, surveillance, is a sort of dystopian view of how AI might impact care. And other words I've heard are impersonal, technocratic, rigid, biased. But on the flip side, there's also these opportunities to be patient-centered, to improve the efficiency of diagnosis, to be more evidence-based, to provide personalized recommendations. And so, of course, the goal here is to work on this left, kinder, more patient-centric focus in AI. So, just to conclude here a little bit on M's word and the patient experience is, this machine thing can't have more punching weight than a patient's story, a human story alone. And so say that working with patients and families is key to the success of these initiatives. And we're really happy that people came here to learn a bit more about it and engage with this topic and have a bit of time to answer questions. So we'll end here maybe. What do you hope AI will do to improve care in psychiatry? Feel free to unmute or ask for clarification. We're happy to answer any questions you might have.
Thank you so much for that very interesting presentation. Yes, if anybody has questions, please feel free to unmute and ask them, or you can put them in the chat. I'm just going to check to see that we don't have. And then I guess while we're waiting to see, my question is it's a bit of a play on the question that you have here. Where do you see AI, you know, moving in psychiatry right now? Like, where are the, you know, what are the things to be looking forward to, or yeah, that's coming down the pipeline, I guess.
Mm-hmm. Well, I don't want to jump the gun. Maybe Nelson, you or have something to say, but I think there's a lot of potential in lots of different areas. Certainly in treatment development, right? So we know it's very expensive to develop new pharmaceutical treatments, you know, to go through, and it's very time consuming. So these models can sort of shortcut that process and hopefully shorten the time it takes to develop new like pharmaceutical interventions. I think that's an exciting space. I think improving diagnosis is also very key, because one, it's, you know, if you can identify someone at risk of psychosis early, you might prevent the negative outcomes that come from experiencing a psychotic episode. And so you can potentially prevent the harm that might come. I think that could be very life-changing for patients. It's also, I think, lots of potential there to involve patients more actively in their care via wearables and smartphones so that patients can engage with the data to really identify what works for them through this process. So, for example, in a project I worked with around major depressive disorder, patients really enjoyed having access to their data through this like a dashboard. They felt it was a very empowering, and so I can see that also being a very positive way to improve the clinical experience and through an illness. Yeah. Maybe Nelson, you have anything that you think, or other people?
I mean, I echo a lot of what you say. You know, it's really, for me, the interesting part is how AI can help us better understand conditions that we never really know much about. One thing that, you know, I've been working on is the HOPE app in suicide. And, you know, we don't really know a lot about the predictors of suicide. And, you know, using AI may illuminate some of the things that can help us, you know, I don't want to say target, but just, you know, reach the people that need to be reached, or have the interventions ready before before it's too late. So that's really exciting for me. Another exciting piece is just the use for our healthcare system. You know, I'm sure everyone hears the news, like all the complaining about what's going on, the poor children at sick kids these days. You know, use of AI can help us free up some space through better understanding of how services are allocated and how we can maximize potential of, you know, our healthcare system. So
great, thank you.